and we will be talking about NEET PG Predictor today, all of you. So just let me know when you can see me, when you can hear me. Am I audible? Am I visible? All of you audible, visible? Can we start? Okay, so all of you, what I'll do is I'll tell you 15 important questions related to systemic pediatrics, and we will be discussing them, and I'll tell you what is important for your NEET PG. So the first question I asked you, and I hope all of you NEET app, this is about a 7-year-old girl who has loose stools. She is not gaining weight. Her weight and height are below the 3rd percentile. So this child is, short and underweight also. Now we thought about celiac disease. Now the TTG IgA levels are 11 times the upper limit of normal, and IgA levels are normal, but TTG levels are very high. So my question to you is, guys, all of you should know the current guidelines for celiac disease. Current guidelines for celiac disease. So what do you think is the current guideline? If the TTG IgA levels are more than 10 times the upper limit of normal. So all of you should know that in your exam, they will definitely ask about approach to celiac disease. So जब भी किसी बच्चे में celiac सोचो, 2 टेस्ट करवाने हैं, IgA levels and IgA TTG2. So why do we get IgA along with this? Because IgA deficiency is seen in almost 5 to 10% of celiac. So we have to look for IgA deficiency in these patients. So if both of them are negative, this is not celiac. Okay. Now if the levels are more than 10 times, so this is according to the Nelson's textbook, according to the European Pediatrics Gastroenterology guidelines, if the levels are more than 10 times, you do an anti-endomysial antibody and HLA DQ2, DQ8. If they are also positive, we start him on gluten-free diet. So my friends, the next step is to do an anti-endomysial antibody. So nowadays we don't do a biopsy in everybody. We do a duodenal biopsy only if the levels are 10 times the upper limit of normal. Okay? याद रहेगा सबको? So in this question, students, you should know the next step. So next step was to test for anti-endomysial antibody and get a HLA. Okay, sorry अगर आपने गलत किया, पर देखो समझना है कि this is the latest guideline for celiac disease, and they will definitely ask you what to test to do, what HLA is associated in celiac disease. चलो next question all of you. Now someone in the chat box is saying कि sir लंबा question है. बेटा 4 लाइन का question है. जब भी question आए तो देखो, make a point out of this. Here's a 10-year-old asymptomatic boy because his sister had celiac disease. Now this child's TTG levels are 2 times the upper limit of normal. अब क्या करेंगे? Anyone? Dr. Kirti, guidelines are stepwise. Okay? So पहले करना है anti-endomysial, फिर करना है HLA. अब इस बच्चे में बताओ, anyone? TTG levels are 2 times the upper limit of normal. And you're thinking of celiac. But since this child is not having, see, this child has no symptoms. ये इस बच्चे को celiac disease नहीं है. This is an asymptomatic child. So in asymptomatic child, your next test will be HLA. Because this child is asymptomatic. अगर symptomatic होता तो हम biopsy करते. Listen to me carefully. In asymptomatic child, you do TTG and HLA. We don't do biopsies in asymptomatic child. So most of you जिन्होंने biopsy बोला, देखो, this is a asymptomatic child. So in asymptomatic children, you look at the TTG and get HLAs. Okay? Remember this. Asymptomatic child, TTG, then HLA DQ2 DQ8. Remember, NEET PG हमेशा पूछता है which HLA is associated with celiac disease. Remember this. Yes, it's tricky, but it's important. Let's go to question number 3. So here is a 3-day-old baby who comes to you with thrombocytopenia, jaundice, hepatosplenomegaly, chorioretinitis, and periventricular calcifications. Periventricular. So क्या आप मुझे बता सकते हैं which torch infection has periventricular calcifications? Of course, CMV. CMV has periventricular calcifications. And हमने यहां बता भी दिया this patient has a positive urine CMV PCR. Okay ना? So what is the most common long-term complication of CMV? Before that, all of you remember, exam में definitely they will ask you CMV. And remember, CMV में CT में दो बातें, periventricular calcifications and cortical atrophy. So small head होगा, microcephaly होगी, cortical atrophy होगा. Okay, cortical atrophy. और टॉक्सो के बारे में क्या याद रखना है? रिमेंबर, लिसन टू मी केयरफुली. टॉक्सोप्लाज्मोसिस में हाइड्रोकेफलस, टॉक्सोप्लाज्मोसिस में हाइड्रोकेफलस एंड कैल्सिफिकेशंस इन द बेसल गैंग्लिया. टॉक्सोप्लाज्मोसिस में हाइड्रोकेफलस एंड कैल्सिफिकेशंस इन द बेसल गैंग्लिया. ठीक है. सो रिमेंबर, सीएमवी में हेड छोटा है, टॉक्सो में बड़ा है. सीएमवी माइक्रोसेफली, टॉक्सो हाइड्रोकेफलस. Remember, this sentence is very important. CMV is the most common torch infection. Number 1, CMV is the most common non-syndromic sensory neural hearing loss in children. Remember, CMV is the very common question in NEET INICET. Most common non-syndromic sensory neural hearing loss in children. Cool? All of you, can you just write cool in the chat box? Cool? CMV is the most common torch infection, the most common non-syndromic sensory neural hearing loss. And we diagnose CMV by a positive urine or saliva PCR within the first 3 weeks. Remember, we diagnose CMV by urine or saliva within the first 3 weeks of life. Okay? चलो आगे चलते हैं. Torch infections are important. Now all of you, what will you think of if I give you a triad of deafness, cataract, PDA? What will you think of if I give you a triad of deafness, cataract, PDA? Anyone? Deafness, cataract, PDA. You think about rubella. You're right. You think about rubella. Remember, the triad of rubella is deafness, PDA, cataract. याद रखोगे, deafness, again sensory neural hearing loss, sensory neural hearing loss, PDA, cataract, or microcephaly, mental retardation, PDA, cataract. Microcephaly, mental retardation, PDA, cataract, or deafness, PDA, cataract. याद रहेगा? Now this is one of my patients. These are my hands actually, and this patient had bilateral cataract. सबको याद रखना है, रुबेला में मिलेगा पीडीए, पेरिफेरल पल्मोनरी सिनोसिस एंड वीएसडी. सबको याद रखना है, रुबेला में मिलेगा पीडीए. डॉक्टर अर्जुन इन द चैट बॉक्स, पेरिफेरल पल्मोनरी सिनोसिस. ओके, पेरिफेरल पल्मोनरी सिनोसिस. Okay, it is not valvular, it is peripheral pulmonary stenosis and VSD. Okay. Now remember, very good question, Dr. Tania in the chat box. See, herpes is usually peripartum spread. Okay, herpes is usually peripartum transmission. Okay, rest are, transplacental, but herpes is usually, transmitted during delivery. So it's peripartum transmission. Okay, of course, CMV is most common, everyone. Now all of you, let me take you to the in thing. देखो आजकल के जमाने का in thing क्या है, to ask you about a case of diabetic ketoacidosis. So all of you, next 5 minutes we will be spending on DK. So you should know the current guideline of DK. So here is a 10-year-old boy, 30 kg, who comes to you with diarrhea, drowsy, sugar of 550, metabolic acidosis. He is dehydrated. What should I do first? देखो सबसे पहले, all of you should understand, all patients of diabetic ketoacidosis, they have solute diuresis. So they are dehydrated. So first of all, let me tell you, my friends, what is DK according to the current guidelines. And the current guidelines are by ISPAD, International Society for Pediatric and Adolescent Diabetes. So this guideline says any child with diabetes who has blood sugar more than 200 milligrams per deciliter or more than 11 millimole per liter and metabolic acidosis, a pH less than 7.3. ध्यान से सुनो, बहुत इंपॉर्टेंट है, pH less than 7.3 और बाइकार्बोनेट लेस देन 18 एंड कीटोसिस. तीनों बातें होनी चाहिए, हाइपरग्लाइसीमिया, एसिडोसिस, कीटोसिस इन द ब्लड और यूरिन. ओके, ये है डीके. नाउ रिमेंबर, जस्ट एक बात याद रख लो, pH less than 7.15 is severe DK. pH less than 7.15 is severe DK, in which you can have deep breathing like Kussmaul's breathing, and he may go into coma. So pH less than 7.15, Kussmaul's breathing, this is severe DK. Okay, now remember, all diabetic ketoacidosis children are dehydrated. Even if they don't look dehydrated, they are dehydrated. So guys, the protocol is to give a bolus, and I just showed you a child's pH tha 7, it was severe DK. So I'll give him a bolus of 20 ml per kg of normal saline. So I'll give him a bolus of 20 ml per kg of normal saline. Then I will start insulin infusion. So I'll start a bolus of 20 ml per kg of normal saline. Then I will start insulin infusion, 0.05 to 0.1 unit per kg per hour. Okay, so I'll start a bolus and then I'll start an infusion, 0.05 to 0.1 unit per kg per hour. याद रहेगा, पहले bolus then infusion. Listen to me carefully. Do not give insulin bolus. Do not start insulin straight away because it can cause cerebral edema. Okay. After the first hour, once first hour is done, so मैंने कहा पहले देना है bolus over 1 hour, then insulin. After the first hour, you continue insulin infusion and make the fluids N by 2. You can add potassium, phosphorus, insulin causes, transcellular shift. So you can, potassium goes into the cell. So hypokalemia, hypophosphatemia. And you add dextrose if sugar is less than 250. So severe, moderate to severe DK, you should give a bigger bolus, 20 ml per kg. So just to make you realize, guys, this is a picture from Nelson's textbook and I will just zoom this for you. ये देखो, पहले देना है bolus 10 to 20 ml per kg, then start insulin 1 hour after fluids are initiated. So 1 hour after fluids are initiated, then you will start insulin infusion. Remember this. So इस क्वेश्चन का आंसर है give bolus and delay insulin for 1 hour. After 1 hour, Dr. Aishwarya. All of you fine with this? Can you just write cool in the chat box? Just write cool in the chat box. Let me ask you one more question related to diabetic ketoacidosis. And here is a 7-year-old girl with diabetes, sugar of 620, pH of 6.8, very severe acidosis, pH of 6.8, ketosis, we give a bolus. Now what should we do next? Anyone in the class? After you give a bolus of normal saline in diabetic ketoacidosis, what should I do next? Her sodium is 132. See, sodium is 132. So if sodium is 132, okay, then I should not go for, it is on the lower side. I will give insulin infusion 0.05 to 0.1. But please, answer nahi hai. Don't restrict fluids. We have to continue isotonic fluids and monitor the baby or monitor the child. So insulin to shuru karna hai, but do not restrict the fluids. Continue isotonic fluids. After another 1 hour, I can go to N/2. Looking at the sodium, this patient has a sodium on the lower side, so I am continuing normal saline here and I am monitoring the patient closely. Cool. Now the next in thing for NEET PG is biliary atresia. Remember all of you, biliary atresia is very important. So exam में एक ऐसा बच्चा आएगा, a 7-week-old child with jaundice, clay colored stools, has a direct bilirubin, almost, cholestasis is direct more than 1. Here it's direct more than, it's 9.5, so it's neonatal cholestasis. GGT is high, biopsy is done. So what do you see in biopsy of biliary atresia? Remember, in each of your classes in DAMS, whether it's online or offline, I always told you, biliary atresia, number 1, दो बातें याद रख लो. Biliary atresia is the most common cause of neonatal cholestasis. Number 1, most common cause of neonatal cholestasis. Number 2, it is the most common indication for liver transplant in children. Most common indication for liver transplant in children. We have to do early Kasai diversion surgery, otherwise 80% children will die. We have to do early Kasai, otherwise 80% will die. Now, best test for biliary atresia is a liver biopsy. Remember, best test for biliary atresia is a liver biopsy, जिसमें मिलता है bile duct proliferation. जिसमें मिलता है bile duct proliferation. Number 1. Biopsy is also done to rule out other causes. Biopsy is also done to rule out other causes of cholestasis. The gold standard for biliary atresia is intraoperative cholangiography. So this is the gold standard. Within, in the OT only, you go for intraoperative cholangiography. Okay, cool. So yes, the answer of this question is bile duct proliferation with bile plugs is seen in biliary atresia. Okay. Phototherapy, it is conjugated jaundice, Dr. Suresh. Phototherapy does not work in conjugated jaundice. Phototherapy is contraindicated here. So next question is again a related question. Here is a child who has 6-week-old child with jaundice, clay colored stools, dark urine, direct bilirubin of 8, gallbladder is small, with a triangular cord sign. Remember, triangular cord sign is a very specific sign on ultrasound for biliary atresia. Triangular cord sign is a very specific sign. HIDA is not specific, Dr. Ishika. HIDA is not specific. Forget about HIDA. HIDA is non-specific. Ultrasound is specific if you see a triangular cord sign, and on liver biopsy you see a bile duct proliferation, bile plugs. Now you should not wait here. We should go for early Kasai surgery here. Otherwise liver will fail and he will require a liver transplant. So yeah, we have to do early Kasai diversion surgery here. Okay, cool. Let's go further. Now we will be talking about some epilepsy syndromes. They are very important for your exam. So here is a 6-year-old girl who gets frequent episodes of stares. She gives a blank stare for 10 to 15 seconds and then she resumes. So there is no aura, no post-ictal phase. She suddenly gives a blank gaze and then she comes back to normal. Okay. So this is a typical absent seizure. Remember, in absent seizure, the EEG shows, and I showed this in the DVT also. DVT is very important, guys. Please start looking at the DVT booklet. Very important. So all over the brain, you can see every second spike and wave, spike and wave. So every second you can see spike and wave discharges. 3 Hertz spike and wave discharges. Drug of choice for absent seizures is ethosuximide. Remember, carbamazepine is contraindicated in absent seizures. Remember, carbamazepine, phenytoin are contraindicated in absent seizures. Question tha, which drug is contraindicated? So remember, carbamazepine is contraindicated in absent seizures. Next question. A 15-year-old girl comes to you with early morning drops. She gets jerks in the morning. She drops things in the morning. So it all started with jerks. And then she reports that they got a GTCS seizure. Whenever she gets sleep deprivation, she gets GTCS. EEG shows 4 to 6 Hertz, polyspike and wave discharges. Okay. So drug of choice, everyone, is this is juvenile myoclonic epilepsy. This is juvenile myoclonic epilepsy. Remember, this is the typical EEG of JME. All over the brain, all over the brain. You can see polyspike and wave discharges. All over the brain, you can see polyspike and wave discharges. Now, दो बातें ध्यान से सुन लो. Drug of choice, remember, drug of choice for JME is valproate. Valproate is the best. But if there is a concern in females of reproductive age group, if there is a concern in females, then levetiracetam is the drug of choice. So remember, valproate is the best. But if there is a concern in females of reproductive age group, then levetiracetam is the second drug of choice for juvenile myoclonic epilepsy. So valproate then levetiracetam. Exam में question ऐसे ही आएगा, NEET PG में ऐसे ही आएगा. If there is a concern in females, then you give levetiracetam. Okay, so valproate and levetiracetam. Now, here is an infant, all of you. Here is an infant, 11-month-old, 6-month-old infant who comes to you with salam, bilateral flexor spasms. So he is having bilateral flexor spasms like a salam seizure or infantile spasms. Salam seizure or infantile spasms. So he was given steroids for 2 weeks with minimal response. So, देखो, drug of choice for infantile spasms is ACTH or prednisolone. So, steroid based therapy, mostly we give intramuscular ACTH. But this child, his EEG improved, but his discharges are still persisting, spasms are persisting. This is infantile spasms. All of you remember, very important for your exams. Infantile spasms have hips arrhythmia all over the brain. All over the brain, there is a chaotic high voltage discharges. all over the brain, chaotic high voltage discharges all over the brain. Okay, chaotic high voltage discharges. Drug of choice for infantile spasms is intramuscular ACTH. The second drug of choice is vigabatrin. So ACTH के बाद क्या है drug of choice? Second line drug is vigabatrin. ACTH के बाद vigabatrin. Only for tuberous sclerosis, vigabatrin is the drug of choice. Only for tuberous sclerosis, vigabatrin is the drug of choice. Now, in this child, we had already given steroids and he was not improving. So, we add vigabatrin. So, remember, according to all the guidelines, after steroid therapy, if the patient is not improving, we add vigabatrin. Okay? After ACTH, if the patient is not improving, we give vigabatrin. Okay? Cool. Let's go further. Now, the next question, which is very important for your exams, is of congenital hypothyroidism. Remember, every baby in the world should get a TSH by heel prick, and the cutoff is 20. So, if it is more than 20, we should evaluate this child. So, this TSH is 100. Okay. बेटा इस बच्चे को डॉक्टर तुलसी दिस पेशेंट वाज लास्ट पेशेंट वाज नॉट हैविंग ट्यूबरल स्क्लेरोसिस बट वी वर गिविंग द सेकेंड लाइन ड्रग एसीटीएच के बाद सेकेंड लाइन ड्रग है इन्फेंटाइल स्पाज्म्स में विगाबैथ्रीन. ओके, हमने ये नहीं कहा दैट पेशेंट है ट्यूबरल स्क्लेरोसिस, हमने कहा सेकेंड आफ्टर एसीटीएच द ड्रग ऑफ चॉइस सेकेंड लाइन इज विगाबैथ्रीन. नाउ फॉर हाइपोथायरॉयडिज्म व्हाट शुड बी द नेक्स्ट स्टेप? Remember, the next step should be a radionuclide technetium scan. So on your screen, all of you, I'll show you a normal technetium scan where you can see that this is the normal thyroid gland and these are the salivary glands. So this is a normal thyroid scan. Now remember that the most common cause of congenital hypothyroidism is dysgenesis of the thyroid gland. Gland ही नहीं बना हुआ, देखो right side पे you cannot see any thyroid gland. 85% of congenital hypothyroidism is dysgenesis of the thyroid gland. 85%. So here you will get a technetium nuclear scan to isolate the thyroid gland. Okay? Remember, it is a preventable mental retardation. पूरे वर्ल्ड में this is the most common preventable mental retardation. Remember, so we have to do TSH in every baby of the world by heel prick on day 3 of life. Let's talk about two more questions. Here is a 9-year-old boy with palpable purpura. Urine shows hematuria and proteinuria, a protein creatinine ratio of 1.2. What best correlates with the high risk of kidney failure in HSP nephritis? Dr. Alankrita Sharma in the chat box, if TSH is more than 80, you should straight away start thyroxine. Remember, according to the Indian guidelines, if TSH is more than 80, don't wait for the scan, you can straight away start thyroxine. So remember, HSP में सबसे important क्या है, and I discussed with all of you in DVT that kidney can be involved. In 30 to 50% of them, they may have nephritis. In 30 to 50%. Nephritis में होता क्या है? Remember, mostly some RBCs in the urine, some microscopic hematuria with or without proteinuria. 95% of the nephritis happens within 6 weeks of illness. Okay, so 95% of times nephritis happens within 6 weeks of illness. So within 6 weeks they get hematuria, they get proteinuria within 6 weeks. Now if they have a lot of proteinuria, a nephrotic range proteinuria, you should do a biopsy. Biopsy shows mesangial proliferation, and then we give prednisolone. But remember, in 1 to 2% of them, they may have rapidly progressive kidney failure. Suddenly, they may have kidney failure, they may have crescents in the biopsy, where we have to go for again biopsy, urgent biopsy to look for crescents, and we give IV steroid and IV cyclophosphamide. Now remember, very important, everyone listen to me carefully. For severe pain abdomen, this is a common question in NEET PG. For severe pain abdomen also, you can give prednisolone. For severe pain abdomen also, you can give prednisolone. So of course, all of you were right that persistent proteinuria, if there is a lot of protein, any cause, whether it's SLE or HSP or Alport syndrome, if there is a lot of protein in the urine, it can cause chronic kidney disease later in life. Now the next two questions are on Kawasaki. Now all of you should know everything about Kawasaki. So I'll next 10 minutes Kawasaki. Here is an infant who has fever, conjunctival inflammation, which is non-purulent, typical of Kawasaki, non-purulent. But that's it, guys. There is no other problem in this child, fever and conjunctival inflammation. There's no rash, no strawberry tongue, oral mucosa is fine. So we got investigations. Coronary arteries are normal. WBCs are 16,000. Platelets are 4.2 lakhs. CRP is 9. So first of all, let me tell you the classic criteria for Kawasaki. पहले basic से शुरू करते हैं. Fever for at least 5 days and 4 of the following. So fever for at least 5 days and 4 of the following. Acute or subacute changes. Acute or subacute changes. A rash, conjunctival inflammation, edema, cracking of lips, and cervical lymph nodes. So I told you all of this in DVT. Fever and 4 of these 5 criteria. Okay, let me see if a rash, edema, cracking of lips. So sound is okay. Okay, it's not too bad. Please bear with me. So fever and 4 of these 5 criteria. Okay. Now remember that the problem in Kawasaki is that they can get coronary artery aneurysms. Okay. The initial risk is 20 to 25%. Now the drug of choice is IVIG, 2 grams per kg, 2 grams per kg. So by giving IVIG, the risk of aneurysms reduces to 4 to 6%. Initially it was 20 to 25%. Now it's 4 to 6%. So remember, drug of choice for Kawasaki is IV immunoglobulin 2 grams per kg. And aspirin we give the anti-inflammatory dose 100 mg per kg till the child is afebrile for 48 hours. So we give aspirin 100 mg per kg till the child is afebrile for 48 hours. Now this child which I showed you had fever and less than 4 criteria. तो इस बच्चे को था incomplete Kawasaki disease. So everyone, I will give you this PDF, very important. Incomplete Kawasaki में CRP और ESR देखते हैं. Okay? CRP and ESR देखते हैं. तो CRP, ESR, if they are high, we get a echo. If echo is positive, we give IVIG. Okay. If echo is negative, you look at platelet count, anemia, albumin, ALT. So if they are abnormal, again you treat at least 3 of the following. एक बार platelet देखे, yeah. CRP ESR. ओके, सो याद रहेगा CRP ESR देखना है, and then platelet count, anemia, albumin and ALT. So let's go back. So this child has, we got the ESR and CRP, they are high. So our next step is that this child has incomplete Kawasaki disease and we will give him IVIG. Okay, and we can give him IVIG. So remember, even if this question, I would have loved to add hemoglobin here, albumin and ALT here, but all of you should at least know कि भैया अब एग्जाम में अगला स्टेप पूछेंगे इनकम्प्लीट कावासाकी के बारे में. तो ये एल्गोरिथम याद रखना कि ESR और CRP, if any of them is high, we get an echo, we look at the platelet, anemia and all of this. If they are still abnormal, we go further and treat. So yes, this child was incomplete Kawasaki disease. याद रखिएगा, incomplete Kawasaki disease. Even if this question, I would have loved to add hemoglobin, ALT, so that I would have made this a complete incomplete Kawasaki disease. Okay. And the last question is, this 2-year-old child has fever, conjunctivitis, strawberry tongue, was given IVIG, but fever is persisting. So my question to all of you is, guys, what is the first drug of choice for resistant Kawasaki disease? What is the first drug of choice for resistant Kawasaki disease? So I told all of you this in DVT also. Please, DVT is the gold standard. Okay, remember DVT is the first aid for NEET PG. Look at DVT. So I told you in your DVT, guys, that resistant Kawasaki is defined as that fever is persisting or it recurs within 36 hours of IVIG. Fever is recurring or persisting within 36 hours of IVIG. और पहली drug of choice है to repeat an IVIG. Most of you were right. The first drug of choice for resistant Kawasaki is to repeat IVIG. Not steroids. First repeat IVIG. Then you may add steroids, use infliximab, anakinra, cyclosporine. Okay, all of you, my name is Sidharth Sethi. If you have any doubts, feel free to email me. Okay, feel free to email me. Okay, and I will answer all your queries. Okay, I can see myself, everything is fine. So just rejoin if everything is fine, any issues on the connection. So like I said, revise your PYQs, revise your PYTs. DVT is the gold standard. एक हाथ में नोट्स रखो जो हमने क्लास में बनाए और फिर DVT को साथ में रखो. ठीक है, अपना टाइम टेबल उस तरह से बनाओ. ओके, नोट्स एंड DVT. एंड इन द लास्ट फ्यू डेज हर रोज रात को PYQ का सेशन करो. All of us, all the faculty of DAMS have spent a lot of time on your PYQs and the PYTs. Please वो सारे sessions देखो. Okay. So I did the systemic pediatrics, and if you have doubts, feel free to email me. Thank you and all the best, guys.